Dear History of Pathology Society members and friends, I'm delighted to welcome you all to the History of Pathology Society companion meeting at the 2025 USCAP annual meeting in Boston. This year, our theme, Serendipity, Unplanned Lucky Discoveries in Medical Sciences, invite us to reflect on the role of unexpected discoveries in shaping our understanding of practice in medicine. Serendipity, the art of finding something valuable while seeking for something else, is not a matter of chance. It is the intersection of curiosity, preparedness, and open minds. Indeed, throughout medical history, some of the most transformative innovations were unplanned. To recall one of the most famous examples, Alexander Fleming in 1928, returning from a vacation, found mold contaminating his bacterial cultures, thus leading to the discovery of penicillin and the dawn of the antibiotic era. Even in pathology, the power of serendipity is undeniable, as we are going to listen from our honored speakers today. But as I just mentioned, serendipity is not only a matter of chance. It is about open minds recognizing opportunities. Louis Pasteur famously said, "Chance favors only the prepared minds." As scientists, physicians, we should be attuned to the unexpected, to allow curiosity, observation, and courage to transform the unexpected in innovation and maybe see the light, as the motto of the USCAP annual meeting this year recall us. This Congress will give us the opportunity for us to share new ideas, starting new collaborations, and in the process, perhaps also encounter at least a bit of serendipity for ourselves. With that in mind, I welcome you to this inspiring gathering, and I wish that you will enjoy our session. But before starting the scientific talks, we placed a very important moment for our society, the Henry Azar Trainee Award, which honors Henry Azar, a founding member of our society, whose legacy includes professorships, clinical activity as pathologist, and not least, a keen interest in the history of medicine. The Henry Azar Trainee Award is intended to encourage next generation of pathologists to study people and events who widen our field of pathology. And I'm pleased to announce that this year, the winner is Dr. Jeremy Minkowitz, Cytopathology Fellow at the University of Pittsburgh Medical Center, with his contribution, History of Papillary Thyroid Carcinoma Nuclei, How Clinical, Pathologic, and Molecular Details Uncover Tumor Nuclear Morphologies. And please, Dr. Minkowitz, I invite you to join us on the stage to give your talk.
'25 is our award, and to Dr. Nikiforov, Dr. Zithala, and especially Dr. Hori for contributing to this project. Today we'll be discussing the history of papillary thyroid carcinoma nuclei, how clinical, pathologic, and molecular details uncover two main nuclear morphologies. Here are CME details, and here are our disclosures. When studying the history of thyroid carcinoma, it's important to approach it from the storied history of the papillary nuclei. These 5 historical revelations shed light on its evolution. Early categorization and standards of establishing malignancy. When describing thyroid tumors in English in the 1920s, Dr. Lewis B. Wilson from the Mayo Clinic wrote in Annals of Surgery that correct early diagnosis of malignant tumors of the thyroid are made probably less frequently than of malignant tumors involving any other organ of the body. Doctors Warren and Meisner in New England wrote in their text in 1953 that the classification on the basis of etiology is completely unsatisfactory because the origin of no type of tumor is known. They proposed three groups of malignancies based on morphologic characteristics and clinical behavior: papillary, follicular, and anaplastic thyroid carcinoma. Dr. Lindsay, working off of Warren and Meisner's text, realized a number of difficulties in concise use of these definitions and classifications arose. His issue arose from conciseness. Mixed patterns of papillary, follicular, solid, and trabecular tumors existed. Papillary carcinomas had follicular features, while follicular carcinomas had psammoma bodies, which at the time were thought to be highly associated with papillary thyroid carcinomas. He therefore suggested that papillary thyroid carcinoma be defined more so based on cytologic nuclear features. The nuclei were quote-unquote correspondingly large, characteristically appeared opaque, as thought to be composed of ground glass. Folding and indentations of nuclear membranes were frequent. The features that we're familiar with, the nuclear grooving. Histologically, he described them as being composed of large uniform cells lying on delicate vascular connective tissue stalks. When describing follicular carcinomas, he took Warren and Meisner's approach as well and broke them up into three different categories. There was a follicular carcinoma where there was malignant follicles that were invasive through the thyroid, and that defined the malignancy. There was invasive adenomas where there was essentially a localized follicular carcinoma. In those situations as well, invasion into the capsule defined the malignancy. And finally, there was an entity called follicular variant of papillary thyroid carcinoma, where there were papillary nuclear features in an adenomatous type lesion that was defined as malignancy. In those situations, there was no well-formed papilla, though poorly formed papillae could exist. These two black and white images are from the original Lindsay text, and these are modern-day color images of similar likeness. So at that point, follicular variant of papillary thyroid carcinoma was realized to not be a single entity. Through Lindsay's data-driven approach, it led to the realization that focally invasive follicular carcinoma and follicular variant of PTC had similar clinical outcomes, which were better than follicular carcinoma. He also identified that follicular carcinoma with lymph node involvement resulted in longer survival. He suggested that follicular carcinoma with lymph node involvement were patients with follicular variant of PTC, though he didn't have enough data to prove that. And finally, as per his text, at least two biologically different processes have been included under the general heading of follicular carcinoma. Chen and Rozai took that idea and designated the follicular variant of PTC papillary carcinoma follicular variant. The nomenclature change that Chen and Rozai suggested in 1977 were based on the follicular variant of PTC acting similar to papillary thyroid carcinomas. And they demonstrated that in their article where they showed that papillary carcinoma and papillary carcinoma follicular variant had similar ground glass nuclei and low rates of mitoses. Psammoma bodies were present in about 30% of the cases, and lymph node mets were more common than distant mets. In his particular cases, though, the particular 6 cases that he presented, 3 of them had infiltrative tumors with no capsule, and 3 had invasive tumors with partial encapsulation. Ultimately, that led to the question of Chen and Rozai didn't explain the difference between encapsulated follicular variant of PTC and infiltrative follicular variant of PTC. In addition to that, there were issues where it was hard to explain why some follicular variant of PTCs were more aggressive than others. Another point that came up was the lack of uniform histology in resection specimens made diagnosis challenging. And finally, there was a lack of consensus on the criteria on various cytologic appearance, which ultimately made the diagnosis challenging. Ultimately, papillary nuclei morphologies are recognized, and by the 1980s, nuclear features became the most important diagnostic criteria for establishing malignancy in PTC. Nuclear enlargement, elongation, chromatin clearing, membrane irregularities and grooves, and pseudo-inclusions all became key points in making a diagnosis. By the 1990s, encapsulated follicular variant of PTC became a well-recognized subset of follicular variant of PTC. In those cases, invasion wasn't required, and PTC nuclear features, which albeit were subject to interpretation and had a high inter-observer variability, were necessary. Ultimately, because of the inter-observer variability and subjectivity, there was debate. So this is a collage that I put together from a sketch that Dr. Kudo made in his text on papillary thyroid carcinoma, where he shows a variety of different features of papillary nuclei. And you have some, as seen on the left, that are more subtle, while more overt nuclear grooving as well as pseudo-inclusions are seen on the right image. And this is to show you that there's a spectrum of papillary nuclei. You have more subtle nuclear features, as seen on the left of this graph, and then more pronounced nuclear features seen on the right. It seemed encapsulated follicular variant type nuclei are often more subtle, while papillary thyroid carcinoma nuclei are often seen in conventional tall cell and other infiltrative type of papillary thyroid carcinomas. Ultimately, that led to a question: what degree and extent of expression is needed for a follicular variant of papillary thyroid carcinoma diagnosis? That became an international debate. In North America, people lean towards calling things follicular variant of PTC with fewer nuclear features. And in Asia, people were more stringent, and they tend to call things follicular adenoma until it was closer to the right side of the little chart that I have over here. And then they would call things a follicular variant of papillary thyroid carcinoma. Molecular testing, though, helped. Molecular phenotypes added objectivity. They helped distinguish between tumors with more developed nuclear features and those without. Between the 1980s and early 2000s, RAS, BRAF, RET, and PAX8 were noticed in various thyroid tumors. And in the mid-2000s, non-invasive encapsulated follicular variant carcinoma increasingly became recognized as an indolent neoplasm. By 2016, it was reclassified as a non-malignant entity called non-invasive follicular thyroid neoplasm with papillary-like nuclear features. The NIFP criteria helped because by using molecular and nuclear grading, it enhanced objectivity. And while everyone agreed that the NIFP entity existed, there still is the same debate as with follicular variant of papillary thyroid carcinoma, whether or not to call this, to what degree of nuclear changes are necessary to make the diagnosis. Papillary nuclear appearance, though, seems to be guided by BRAF V600E-like or BRAF V600E mutations. And so classic PTC and infiltrated follicular variant of PTC show more significant nuclear features, and lymph node mets are more commonly seen in those entities than with encapsulated follicular variant of PTC, NIFPs, and follicular carcinomas, which have these RAS-like mutations. They have more subtle nuclear changes, and they tend to have distant metastases barring the NIFP entity. Ultimately, the future direction in thyroid and other parts of pathology are with AI. And here are some journal articles that describe AI being implemented in thyroid diagnoses. But ultimately, the question is, can AI reliably recognize papillary nuclei? By whose standards? In histologic sections, in cytopathology? Will AI be able to predict thyroid molecular profiles? And ultimately, will this lead to better concordance between cytologic and histologic diagnoses? Thank you. Yes, any questions?
You have to say from the audience, yes.
This is not a question, it's a historical note, which I discussed with Jeremy a minute ago. The first description of the clear nuclei was by Nathan Friedman. Nathan Friedman, you may know because he wrote the still existent classification of testicular tumors, when he was at the AFIP. But after that, he became chairman of pathology at, or I guess it was director, not chairman, at the Old Cedars of Lebanon, where he saw those and described them as hot eyes, those round, clear eyes, because he thought they looked like the eyes of Hazel Scott, who was a movie star, a very popular movie star. His first resident in his role as chairman was Nancy Warner. Nancy Warner went on to become the first female chairman of a pathology department at USC, of a pathology department in the United States, the first woman pathology chairman. And she didn't like the name Hot Eyes, so she called them Little Orphan Annie Eyes, because she read the newspapers.
Great story.
Thank you.
Thank you.